Good morning, good afternoon, and good evening, depending on where you are in Canada or elsewhere at this moment. I'm happy to invite you to the third webinar in a four-part series, which is leading up to the summit, our 7th annual summit called Patients Redefining the Future of Healthcare in Canada. And today's topic is value-based healthcare, resiliency, and beyond. So I'd like to start by acknowledging that I'm speaking to you from Toronto, which is located on the traditional territory of several nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. And it is covered by Treaty 13 with the Mississaugas of the Credit. We thank them for sharing these lands with us. So I'd first like to thank our sponsors for this event. We can't do these events without sponsorship. These are our sponsors for this event: Pfizer, Amgen, GSK, Janssen, Innovative Medicines Canada, Leo, Roche, and AbbVie. And we would also particularly like to say a special thanks to Axon. And Axon is the organization that does on an in-kind basis our all our IT work for this event. And we really thank them for that generosity. And so just a few housekeeping rules. During the presentations, and there will be two, one from Eva Villalba, who I'm going to introduce a little more formally in a moment, and myself. We'll mute all the lines, and all videos will be kept off as well. But you can, at any point, go into the chat and put questions in the chat. And we will be just put it in and press enter, and we will take all the questions at the end of the two presentations. We are recording in both English and French, and if you want to listen to this webinar in French, just click world icon at the bottom of your screen and click mute original audio and select French. And last, if you have any technical difficulties during the course of this, please contact Axon Technical Support at the chat function, but we hope that will not happen. So, as I've said today, I am joined by I was going to say queen of, but I'm not sure if that's how you'd like to be thought of. Certainly the leading expert in Canada on value-based healthcare, and a dear friend and colleague, Eva Villalba. She's the executive director of the Quebec Cancer Coalition, which is an influential Canadian nonprofit sector patient advocacy group, and it's dedicated to improving the Quebec healthcare system for people affected by cancer. Since 2008, she's been involved in healthcare charities, advocacy groups, and nonprofits. Eva's the first Quebecer and Canadian to obtain a graduate degree in value-based healthcare with a Master of Science in Healthcare Transformation at the University of Texas in Austin. She's also the co-chair of the Resilient Healthcare Coalition, a group with which I'm very pleased also to be associated. She has a VBHC Green Belt certification from VBHC Center Europe, and is their official Canadian ambassador. Oh, maybe that's what I should be calling you. I should be calling you the ambassador of value-based healthcare for Canada. Eva's a fierce patient advocate, as any of you who know her can attest, and believes strongly in the potential of Canadian healthcare systems to be world-class leaders in value-based healthcare. And just for those of you who don't know me, my name is Louise Binder. and I'm a patient health policy consultant working with Save Your Skin Foundation, which is a national nonprofit group for oncology patients who have skin cancer and melanomas, including melanomas. So I'd like to turn it over to Eva, who is going to explain all about value-based healthcare, everything you've ever wanted to know and more.
Thanks for that, Louise. So I'll just share my screen. Is it working? Okay, great. So welcome, everyone. Louise is right. I am extremely passionate about this topic. And so you might have heard, it's becoming a bit of a buzzword, value-based healthcare, or VBHC. And today we're going to demystify some of that, but beyond the concepts, we'll do a little overview of the concepts, and we'll go into like, what does this even mean, and more specifically in Canada. So where did this all start? This started with Professors Elizabeth Teisberg and Michael Porter. They are PhD doctors, not medical doctors. And Professor Porter is actually really well known for speaking about value in the context of added value in business strategy. He's a very well-known business strategist from Harvard Business School, and Professor Porter was also a professor at Harvard for a while, and she has a PhD in systems engineering. So it's really a concept that came about not because of their academic expertise, but because Professor Teisberg was actually living something with her own children. She had 3 children that had that were very sick as infants, and she had to navigate the healthcare system. And in speaking with her colleague Michael Porter, they realized there has to be a better way. And so they really began by looking at what does value mean in the context of healthcare. So in order to do that, we have to think about, like, what is the mission of healthcare? What is the purpose of healthcare? And really, what does success mean in the context of healthcare? It's confusing because what we're rewarding isn't what it should be, right? So if we think about value in the context of healthcare, the only goal that actually unites everyone is the only one that has the interests of all stakeholders is value for individuals and families. Better health outcomes for money spent. And that's really how this seminal book, Redefining Healthcare, came about in 2006. So how do we design a healthcare system to actually improve patient value? And in the US, this element that Michael Porter was very famous for was competition based on results. You know, we should be competing to be the best at what we're doing. And I'll talk about that in a second, but it has a different connotation in the context of our Canadian healthcare system. So the value equation that was proposed by Porter and Teisberg, and that has since been adopted by ICHOM, the International Consortium of Health Outcomes Measurement, by CIHI here in Canada, and also by VBHC Center Europe, is basically that value equals an improvement of outcomes that matter to patients relative to the costs, but not just at one time, but throughout the entire patient journey. And just by saying that, we realize that that's not what we're currently doing at all. We're looking at costs at one specific time for one specific thing, not over the entire trajectory of care. And we're not really looking at outcomes that matter to patients, but more clinical outcomes, or even maybe process metrics that matter to health systems or managers. Then more closer to my home in Quebec, the Ministry of Health a couple of years ago, in about 2018, started to become interested in the question, and they were looking at the value equation, but also adding elements of, you know, how do we better use resources? How do we enable better access? And then give that to the most amount of patients possible. So that's that other element. And across the pond in Europe, they started working on, and this is from the European Commission. There's been many papers coming out of Europe, and I have to say that they're quite a bit more advanced than we are here in North America in terms of applying it at a larger scale and for longer. So there's many examples of, you know, 10-year implementation projects that have been going on in Europe, which we definitely don't have here in Canada yet, but ask me again in 5 years. And so the European perspective is interesting because their healthcare systems are much more similar to ours here in Canada than the American system. So it's very interesting to see that, yes, they look at, you know, value-based healthcare in terms of improvement of outcomes. And that's, you know, they look at it with 4 pillars. And the 4 pillars are personal value, so helping people to achieve their goals, or patients. The technical value is, okay, how do we achieve the best outcomes using the best resources available, or the resources that we have available. Allocative value is that equity piece, achieving fairness in how we actually deliver healthcare across populations. And it'll be no surprise to you that that is not explicitly in the American model. But it should be in ours, in the Canadian one. And then societal value. So how does this act as a positive force in social health and cohesion? And again, this is very relevant in our Canadian healthcare system. That's definitely part of our values, more so than explicitly in the American ones, I would say. And so there's also some related VBHC concepts that sometimes get thrown around. So yes, so I basically told you what VBHC is, but in Quebec, we have learning health systems, which are really, we're starting to talk a lot more about this, Système de santé apprenant, and there's a lot of overlap. There's also overlap with the patient partnership model, or the Montreal model of patient partnership that we like in Quebec, and that's really starting to spread across Canada and even across the pond in France and elsewhere in Europe. And what all of these things have in common is that the patient is at the center of the decisions, right? So our healthcare systems currently, I mean, we could say that we're putting the patient at the center, but we're not really. We're not including them. We might be doing things for them, but not with them. And that's really the patient partnership model of co-creating with patients, not just for them. Also in patient partnerships, the patient experience is really important, as it is in value-based healthcare. And value-based healthcare and learning health systems also have the commonality of being particularly invested in this continuous improvement cycle. So it's not like a one and done deal, but it's a continuous learning based on the data that we're collecting. So the patient is at the center, but perhaps more specifically, patient outcome. And I think that's a good way to understand all of these buzzwords. And I would maybe add a fifth kind of definition that sometimes gets thrown around and confused with value-based healthcare, and that's the quintuple aim. That used to be the triple aim and then quadruple aim, and now it's the quintuple aim. It was developed by the Institute for Healthcare Improvement in the United States, and it looks at improving healthcare by across 5 dimensions: patient health and experience, health equity, the health of service providers or health professionals, population health, and system efficiency. However, it's not quite value-based healthcare. It has evolved and it's akin to value-based healthcare, but I wouldn't say that it's the same thing, and it's not as transformational, in my opinion, as value-based healthcare is. So where's Canada in all of this? I really believe that Canada has an incredible opportunity. We're at a great moment in time right now. Medtronic and The Economist, they did this report a few years ago, and it was all about, the readiness of different countries for VBHC. And Canada actually scored really well, in particular because we do have patient-centered care. It's the first metric is outcome-based care, and patient-centered care. I think we're stronger on the patient-centered than we are on outcome-based, but we're getting there, and we are starting to collect things, even though the data is very disjointed. The second element is bundled payments, pay-per-performance, linked to quality. We have limited applications, but it does exist, especially in like hip and knee replacement and transplants, and in certain fields. I think we could do better, but we're better than other countries, so that's good. And then finally, quality standardization, which is definitely the case. And we have a couple of really great opportunities, I believe, in terms of the readiness of our health systems in Canada, not just one, right? We know that it's heterogeneous and each province does their own thing. So I'm really happy to see that in Quebec, for example, with the new announced healthcare reform, there's a lot of talk of specifically VBHC and language about patient experience and patient partnership. We know that at INES, at the Wellness Commission level, and even at Minister Dubé's cabinet, there's a great appetite for value-based healthcare. We know that in Ontario, they've been doing great things with value-based procurement, even bundled payments, and they have a dedicated VP of VBHC. In BC, there's also in Providence Health, they've been redesigning a whole new hospital with value-based healthcare practices with Dr. Shannon Jackson, who's also an alumni of the Value Institute from this last cohort. And finally, we know that Alberta is also doing great things, specifically with the data and outcomes piece. So I'll quickly go over like principles of outcome measurement is key. So it's not sufficient to do value-based healthcare, but without outcomes measurement, you're not doing value-based healthcare. So it's a necessary step, but it's not sufficient. And what do we need to do? Well, historically, we were just looking at provider behavior, like volume of services, right? But what we need to move towards, what does it mean? What is a metric of patient success? How do we define success? And we define success by looking at health improvements. So outcomes by condition. So not generally, but looking at what are the shared needs of a certain patient segment or population, and then looking at what are the outcomes that matter to that person and measuring them throughout to see an improvement. So it's not for a specific procedure or a treatment, but really for a specific condition, for example, early age onset colorectal cancer. Outcomes are always multidimensional and they're important in all cases, but we know that they're not currently, it's not part of our practice yet. And that's kind of what we're working towards. It's over the full cycle of care. It's not at one moment. And it has to be standardized. So what's interesting in value-based care is that the measures are standardized, but what's important, it's about 80% of things are standardized in value-based care, and about 20% are personalized or adapted to patient preferences. And so that's something important to keep in mind. So historically, we measured clinical measures, we measured process, we measured maybe some costs, like, oh, that drug costs too much. But did we actually measure patient-reported outcomes? Did we measure avoidance of hospitalizations? Did we measure, the cost over the entire cycle of care? Did we measure value from the perspective of patient or their experience? Not yet, but we're working on that. Why should we even measure this? Well, by measuring these outcomes, we identify variability, unwanted variability. Some variability is normal and expected, but some variability is certainly not and can basically point us towards some very important health inequities, but also discrepancies that are not clinically explainable. And so here's an example, like in Great Britain, there's a twofold variation in survival rates for lung cancer. We should know why that is. There's a 30-day difference in mortality rates for COPD. And then a colleague of mine in Brazil, Dr. Marcia Macadisa, and her group did an incredible atlas of variation in healthcare based on the work from New Hampshire originally. And it's basically about identifying these differences. And then you see, is it normal to have one place that has 15% cesareans and another place that has 80? There's no real clinical reason for that. Why is that? Maybe it's because the incentives are in the wrong place, but if complications are worse, then it's costing the healthcare system more. So these are examples of why measuring outcomes are important. And we know it's been shown that actually measuring outcomes improves the quality of life, but also even survival of patients. I don't have that slide, but if anyone is interested, I definitely have the peer-reviewed articles to point you in that direction. And so in order to standardize these outcomes and not for everyone to do their own thing, and then we can't compare, we can't benchmark, there's a couple of organizations that spring about. So the International Consortium of Health Outcomes Measurement, Dr. Michael Porter was part of building this, and it's in the US and in Europe. And they basically developed the standard sets for multiple conditions. I believe they're at this says 36, but I think they're at like 40 something now. And it's basically just standardizing those outcomes. And then more locally, you can see which ones are most important. But there's also other initiatives like PCORI, like PROMIS, like ISPOR, and they've also developed standardized measures of PROMs or patient-reported outcome measures. So now that we know that, how can we move from all of these concepts that we've been talking about for over 10 years, and how do we move to actually implementing? What does it look like when we actually operationalize VBHC? What are the necessary steps to actually create that value for everybody? But of course, Louise and I will always remind everyone that VBHC, we have to really measure value from the perspective of patients first. And if it's good for patients, it's good for everyone, but not vice versa. So Porter and Lee actually did propose an implementation framework, a strategic agenda to implement value-based care based on these 6 elements. And I won't go into detail today because we don't have time for that. But the important thing is that they're not sequential steps. And traditionally, people have done one. They've organized into integrated practice units, or they've measured outcomes, or they've looked at costs, but really they're mutually reinforcing and they have to be done all simultaneously. I would say that 4 and 5, especially 5, is not as pertinent in a Canadian context, in the sense that that's really there for private hospitals to make money, and that's not relevant in the Canadian context. But number 6, which is build an enabling information technology platform, that data piece is also crucial and needs to be found in every element. And I will touch on that a little bit more. Meanwhile, Elizabeth Teisberg and Scott Wallace from the Value Institute for Health and Care, where I did my master's, they actually developed this model to implement high-value healthcare, which is how to implement VBHC, basically. So you have to start from, the understanding the shared needs of patients. So what is your patient segment? What are their needs? Then you design solutions to improve these health outcomes. Then you integrate into learning teams, or that integrated practice unit, but continuously learning, like that learning health system element comes into play. You have to measure health outcomes and costs, and then expand partnerships. So look to collaborate, look to integrate care across, outside of the hospital, not only in the hospital, across teams. And so these are some elements that they touched on. VBHC Center Europe talks about 4 lenses, 4 perspectives that are essential in order to implement value-based healthcare. So there's the patient perspective, the medical perspective, the cost perspective, and the organizational perspective. And in order for this to work, all of the key stakeholders have to work together. So HCPs are healthcare professionals, patients, payers, and industry. But then there's all of these other satellite kind of stakeholders that are essential. And I'd like to highlight the role of patient advocacy and patient support groups in particular. But there's other factors that come into play. And ideally, again, it doesn't work if only one or some of the stakeholders adopt this value-based healthcare perspective. It really has to be a cultural transformation that is embedded in all of these stakeholders in order for VBHC to really work at scale. Meanwhile, in Europe, EIT Health also developed an implementation framework, and I recommend it. It's a great book. I know some of the authors, and they also identified kind of the steps that were necessary in order to implement it. So I think this is closer to what we need in Quebec and Canada. But now in practice, I could have given you lots of international examples, but I'm very happy to briefly talk to you about a great innovative example that we're actually currently in the process of doing and implementing at the Jewish General Hospital, in which we are specifically looking at adapting that implementation, that VBHC implementation framework, to a Canadian context. And so these are our goals. We want to see what is the practical application of this, value agenda in the context of specifically oncology, of cancer care in a Canadian context. We're looking to document and validate a scalable VBHC implementation framework. So like not just for the hospital where we're doing the study, at the Jewish General Hospital, but also to see how can we scale it elsewhere in other cancer types, in other hospitals that might not have the same infrastructure. We're aiming to create evidence around the impact of what is the impact on health systems of this VBHC transformation, what is the impact on patients, what is the impact on system efficiencies, and I know that Louise will talk about this in a moment, but that's part of the reason why this is the right moment to do this kind of work, and to validate the implementation framework. We have 4 project objectives, 4 specific project objectives, and we're very much on track to delivering them on time. This is a 2-year project, which will, year 1 will finish in February, and then we'll have a whole year 2 of collection. So the first goal is to develop an integrated practice unit for colorectal cancer by mapping out the colorectal cancer trajectory at the Jewish General Hospital. And then building an IPU based on that, to incorporate PROMs and PREM collection into the standard outcome measurement and care, and just that's actually a culture change to embed that into the way that things are done. And what's really interesting about our project is that we're measuring PREMs and PROMs in real time and giving patients feedback in real time. And that's completely innovative. Usually these PROMs are collected and then you have a learning cycle every 3 months. And then it's very detached from, how it will impact the patient in real time. The third one is to optimize that care trajectory based on, identifying inefficiencies and waste and unwanted variability, like I mentioned before, and to assess patient status and respond in real time. And then finally, create a VBHC dashboard that tracks and shares the data across that integrated practice unit, which includes clinical outcomes, PROMs, resource utilization like beds and, infusion chairs and things like that, the cost of care, processes, and clinical administrative data like emergency room visits, for example. So what's the expected impact? On the micro level, which is the most important to patients and families, is that we aim through this project to demonstrate that a VBHC approach actually improves health outcomes, including quality of life for patients and families. At the meso level, or the middle level, we actually are looking at how can we restructure an organization and work processes of multidisciplinary teams or integrated practice units, which is a step beyond multidisciplinary teams, to achieve value in healthcare. And then at the macro level, which is what I'm most excited about, it's really about transforming healthcare to make better decisions based on value, and value that is measurable. And not like an ultimate number, but a relative number even, that would help us to make better decisions. And we've seen at what point that was important in the context of COVID with the dashboards. In Quebec, we had these daily dashboards with all these metrics about where we were at in terms of vaccination, in terms of ICU capacity for COVID, in terms of testing, and that allowed us to make better decisions in real time. So I'm almost done. I have 2 slides left. Some of the things that I'm most excited about is that value-based healthcare really has, we're starting, I think all stakeholders that were presented before are starting to really understand the promise and potential of VBHC at the level of HCA, at the level of access, at the level of outcome-based agreements. It really allows us to reflect about, how is our health system being financed right now, and are we incentivizing the wrong things? Currently, we're incentivizing volume. We're incentivizing healthcare services. We're not incentivizing value or health outcomes. So we have to think about that. Is the way that we're financing the healthcare system, does it still make sense? I mean, in Quebec, we're still financing hospitals based on like how much we gave them last year, and then adding inflation costs. That doesn't make any sense. The money should follow the patient, and that should be tied to outcomes. And that's really a value-based perspective. Value-based procurement as well is, yes, this Da Vinci robot costs more, but if it actually prevents rehospitalizations, complications, it allows people to go back to work, then there's greater value. That's an example of value-based procurement. Healthcare transformation, I believe I talked about it. Industry transformation, I think in terms of the pharmaceutical industry, those that actually understand value-based healthcare and get on that bandwagon and are innovators and pioneers, I believe will have an advantage. Value-based competition on results, I also think that even at the level of hospitals, at the level of healthcare providers, they do want to do their best, but currently they're just assuming that they're doing their best. And I think that we need more transparency. Populations are asking for more transparency, and that'll actually allow them to compete based on results, not to make more money, but to get better outcomes. I think that's more relevant in a Canadian context. And then finally, with precision medicine and real world evidence, I think there's a great opportunity in VBHC, but we won't go into those details. So my last slide will be a nice segue into Louise's talk. I think that the pandemic has actually been a, terrible, but also great in terms of being a catalyst for health system transformation. I think that we've seen that we can do so much more than we previously thought we were capable of. I think that it has shown us how important health data is, but health data in real time in order to make better decisions. It has shown us the cracks in our fragile system, and it has shown us that that is not acceptable, and we need to, prevent that from happening again. And I believe Louise is going to talk about that. It has shown us the really negative impact of having functional silos of departments not talking to each other, and about the need to, during the pandemic, even provinces were talking to the federal government and to each other and coordinating care. What a concept. But even at the level of the hospitals or of the healthcare systems, there needs to be, more of that breaking of the functional silos and more transversal action, because the patient doesn't care what silo they're in. They're going across. And so the data, the money, everything should actually follow the patient along their care trajectory. But that's not the way our system is organized currently. And I think that the pandemic really showed that. So we need to understand and measure value. We saw during the pandemic that predicting and preventing is much better than break and fix, and it's cheaper. It's cheaper for everyone. So it's really a value to all stakeholders. We learned that the right treatment at the right time for the right patient is essential. Imagine if we just waited to get vaccinated after everyone else had gotten vaccinated, or, imagine that we didn't have all of the new treatments that we have. We would have a lot more hospitalizations. These are just lessons, but that we shouldn't lose, right? And then finally, in terms of incentives, we really need to look at rewarding value and not volume. We need to aim for the health of the population, not just giving services. We don't all want the best ICU services for COVID. We want to not ever have to use the ICU, right? So the incentives have to reflect that, and that's not what currently exists. We also need to think about, that cost vision of only cost. We need to realize that cheap isn't better if you get no results, or if people don't take the medication, it's not actually cheaper. And then finally, how do we finance and reimburse healthcare? So I will stop there and pass it on to my dear colleague, Louise. And then we can talk a little bit more about what this means in the greater context of health system resilience and going forward. During a pandemic, the pandemic is not finished yet. So thank you very much. And we'll take questions after Louise. On to you, Louise.
Eva, thank you so much. I'm just so delighted whenever I hear you speak. Of course, you're singing my song, so why wouldn't I be? And I'm just amazed also that you've done so much with this pilot project, or proof of concept, I like to think of them as. And I certainly hope that once the results come out, it will be proof to everyone that we're quite capable of doing this. And as you say, it's not about the volume, it's about the value. So thank you, and we'll have more chats about this. As Eva mentioned, I'd like to talk to you for a couple of minutes about some of the core concepts that underpin a really value-based healthcare system. And as she mentioned, we both belong to a few coalitions, one of which is called the Resilient Healthcare Coalition. So those of you who know me know that I always start with definitions, because one of my experiences of working in this area is that people think they're talking about the same thing because they use the same word, but they may mean very different things. And I would say that a case in point is the term pharmacare. And if you ask everybody, they're all in favor of it. But if you ask them what they think it means, you might find that they're in favor of some very different things, one from another. So if we could look at the definitions next. Let's just make sure that we understand them. So what is something that is fragile? it's something that's easily destroyed, ended, or made to fail. And it's the opposite of being robust, which is something that is strong and unlikely to break or fail. Resiliency, which is the word we hear so much about, is the ability to quickly return to your original shape after being bent, stretched, or pressed. And the operative word here is usual state. So this is very important in the context of what happened to us in the pandemic. If you're resilient, that is, if you start out in a strong position, then something like a stressor, a pandemic, once you get it under control, should take you back to where you were before that happened. Now, that's a good thing if where you were was where you wanted to be, if you were in your ideal state. I would certainly argue that we were never in our ideal state, certainly in the cancer area, even before the pandemic. So returning to resiliency, returning back to where we were, is actually not good enough. It's getting us closer, but it's not good enough. And in fact, just this morning, I heard on the news, I think people think all I do is listen to the news, which is actually kind of true. I heard tragic stories from Ontario about breast cancer screening and how much breast cancer screening has been down as a result of the pandemic. And that even now, when people start talking about us coming out of the pandemic, which I think is also an arguable point, we are not getting back even to resiliency. And people are coming in, fewer people are being screened for breast cancer in Ontario, and those that are coming in more severely ill than they would have been before the pandemic. So even resiliency would be something, but it's not the ideal, I would argue. I would argue the ideal is anti-fragility. And I wish that I had dreamed up this concept, but of course I didn't. I just steal stuff from smart people. And this is a concept that probably other people have used, but I think the person who's most associated with it is a man named Nassim Taleb and Nassim Nicholas Taleb. And he's written 4 books. The last 2, the second last is called Anti-Fragile, and the last, which I think would resonate for all of us, is called Skin in the Game. And that is certainly one of the things that he thinks is a very important part of being anti-fragile and wanting to be anti-fragile. So what does it mean? It's a concept that means that when you actually have a stressor or a shock, like a pandemic, you actually come out of it improving your results. And it means that you don't return to the resilient state that you were in before, but you transform into a more robust state. And it represents an opportunity to ensure against future uncertainties. I would make the argument that cancer is an epidemic. It's at epidemic proportions in Canada, and it's in pandemic proportions across the world, and that we should be, as we did for COVID, trying to reach anti-fragility. That is to transform, and I would argue to a value-based healthcare concept, as described by Eva, into a more robust state. So let's go to the next slide, and let's talk a little bit more about these concepts. As I've said, if we look at what happened to the healthcare system as a result of the pandemic, it fell apart pretty quickly with the COVID-19 stressor. So that tells us that it wasn't resilient, and it couldn't even return to its former state within this context. It was already lacking resiliency, and frankly ended up, as I've mentioned with the breast cancer example, ended up in a worse state than it ever was. So I would argue that our healthcare system in Canada, and I know that Eva mentioned this as well, is fragile. It's breakable. It's bendable. And the original state is not adequate from the outset. In my view, it never was. And returning to that original state is not enough. So this calls for the calls for resiliency that we hear should not mean returning to the former broken system. And as Eva mentioned, it shouldn't be fixing what's broken. What we need to do is to move right back to the early prevention and dealing with things in a preventable way and in an early detection way, so that we're not just, fixing up the cracks in a broken system. Now, interestingly enough, we did do that with the pandemic, with COVID. We did many. It's okay. You can go to the next slide. It's fine. For the purposes of COVID, we got very anti-fragile, and I'm going to give you some examples of that, which proves to me that there's absolutely no reason why we can't be anti-fragile as a general rule in the healthcare system, not just with one virus. So how do we make, if you believe me, and I hope you will, that there is a possibility to make our healthcare systems anti-fragile? What do we need to do? I'm arguing that what we need to do is to incorporate the lessons learned from crises, including this pandemic, and they should be the best practices and innovations, and we should keep them. And that will make us anti-fragile. It will not just return us to where we were, it will make us better. And we need to invest in insurance. And I'm going to explain what I mean by that in a minute. So if we go to the next slide, let's talk about some of these great pandemic best practices. So prior to the pandemic, I'm going to start back with HIV, because as everybody knows, that's where I come from. That's my original gang. Prior to the HIV pandemic, the drug approval process at Health Canada and other healthcare systems in other countries didn't recognize the need for a more expeditious approval process for life-threatening and debilitating diseases. But we explained to the government why people who are going to absolutely die if they don't try particular drugs, even if it turns out those drugs aren't successful, it's kind of a we have nothing to lose approach. And so we convinced them to bring in the notice of compliance with conditions. And they were not just a temporary measure. They were a measure that were brought in by one disease group, but in fact have stayed with us. And I know that they are being used in cancer reviews and probably other reviews as well. So the system became stronger as a result of the HIV pandemic, as a result of actually implementing that best practice and that innovative approach as the norm. And they didn't go back after we got HIV drugs. They retained that best practice. So here's some more examples that we should talk about. We could go to the next slide. Let's look at COVID. We developed and rolled out COVID-19 vaccines very quickly. Now, what are some of the ways we did that? Generally, Health Canada will not look at a file until all the data are in. But as we've been arguing for 25 years, there's no reason why they can't do what are called rolling reviews. That is, take data in and look at it as it comes in, and then add and add and add, so that by the time you have all the data, you have had an opportunity. You're not starting from scratch, you're following along. And they did that for COVID, and they should be doing that for all reviews, certainly of drugs that are required for NOCC, that are for life-threatening and debilitating purposes. That would make us more anti-fragile. rather than just returning to the norm. So they fast-tracked those drugs, as I said. We had the opportunity, we do have the opportunity to learn from that approach, and we should be implementing it all across. We expanded virtual care. And before that, I don't know about virtual care. And suddenly it became a safe alternative for patients to maintain their healthcare appointments. And I would argue that now we have an opportunity to analyze what worked and what didn't in virtual care, now that the state of emergency has at least slowed down, and use it as an ongoing tool in the right places to be more anti-fragile. So that's some of the examples from COVID that I really believe should be implemented. If we go to the next slide, I want to talk for a minute about insurance, and I've not gone into the insurance investment business, but I want to talk about insurance in our healthcare systems. So in the late 1990s, in collaboration with the World Health Organization, Canada created what is now known as the Global Public Health Network, GPHIN, under the Public Health Agency of Canada. Nobody knew much about it. I didn't even know it existed, I confess. It effectively followed global pandemic surveillance. It surveilled all across the world and warned us about disease outbreaks, food and water contamination outbreaks, bioterrorism outbreaks, chemical exposure, and natural diseases. And it was considered world-class. It was effective in detecting Ebola early, SARS, West Nile viruses, and other outbreaks. However, in the 4 years leading up to the pandemic, surveillance became not well coordinated and GPHIN was understaffed. The turnover of critical staff was not recovered following cuts by the former conservative government. And I think all governments have a bad rap on this one. They just happened to start the ball rolling, and no government really improved it. So it was this kind of story of, well, wait a minute, we haven't had a pandemic for so long. Why do we need to? It's like house insurance. My house didn't burn down last year, so why should I get fire insurance for it this year? Well, that's the point of insurance, right? And unfortunately, I don't know to what extent GPHIN might have made our ability to be anti-fragile better during this pandemic. It's, 2020 hindsight, but we certainly are moving back to bringing GPHIN in, and I'm so glad to see that. And I really hope that it is permitted to do the job that originally was doing and was so well respected for doing. So part of anti-fragility is the concept of insurance. Some people say it's building in a bit of redundancy. I would argue that that's not really what it is. It's ensuring that you have things in place in case of an emergency. That's not redundancy. So, so we move to the next slide. As I've mentioned, GPHIN's back. It's not sunken costs, it's insurance. As I've said, the fire insurance example, anti-fragility could certainly be further strengthening systems like GPHIN and developing more sophisticated global infectious disease surveillance systems. And we really do need this because sadly, we all know that we're going to have a number of further future shocks to the healthcare system, where you don't have to be a genius to see that. We see that with all the terrible climate change issues that are coming up and the threats of bioterrorism, and etc. So we need this insurance, and it will make us more anti-fragile. So we need to support that early prevention, both, as Eva mentioned, at the individual level and even at the country level, but also internationally. So those are, if we want to go to the thank you slide, I once again thank Eva so much for all the hard work she's doing to make us an anti-fragile system in Canada and hopefully across the world. And now I'd love to turn it over to questions if people have some for either or both of us.
And maybe while we're waiting for questions, I have two comments. One is that was great. Thank you so much, Louise. One is that our project is not a pilot because we all have pilotitis and we don't want more pilots. Our project is an iterative project or a demonstration project. It's really about not just showing that it can be done, so not just the feasibility, but also using that to scale. So we're actually including in our strategic committee, for example, people from Kai people from BC, people from the next hospital that will be applying this, that has a very different infrastructure and culture, which is the UCPQ, the Lung Cancer Institute in Quebec City. And so we're really building in the scaling up from the beginning. And so it's for sure not a pilot. That's number one. And that, because, you know, pilots die, pilots just stay pilots, and that's not going to help. The second thing that I would add in terms of resilience and anti-fragility is that I would also add, related to what I was talking about at the beginning, that one of the things that makes our systems anti-fragile is that learning health systems approach. So if we use the data for every bad thing that happens, if we learn and then we can avoid it from happening again, then that makes a system anti-fragile. So the example given by Nassim Nicholas Taleb is like the black boxes in airplanes, you know? So like every time there's a plane crash, air safety gets better, right? We don't want a plane crash, but every time one happens or there's an accident, then every time air safety gets better internationally. And I think that's what we need at the level of healthcare, and learning health systems is one place to do that. So now questions are coming in. Go ahead, Louise.
Okay. So one question is, what opportunities for patients and citizen groups, what are the opportunities to support value-based healthcare to move forward to an anti-fragile healthcare system? Go ahead, Eva.
Well, I mean, the fact that it's a patient group like ours, the Quebec Cancer Coalition, that's actually leading the charge, that I discovered value-based healthcare through Louise Binder and the Patients Redefining Healthcare Summit in like 2018. That is an example of how patient advocacy groups and patients themselves, because we always do things with patients, not just for patients. Even in our own project, we have patient partners that are co-creating the whole methodology, the whole process with us. We don't do anything for patients, we do it with patients. So I think these are examples of just asking for that, embedding it in your recommendations, you know, really understanding it. And that's why it's really important that we're all on the same page when we talk about value, so that we can, in our own context, in our own jurisdictions, like start to talk to those other stakeholders. But I really do strongly believe, and I know Louise agrees with me, that patients and patient advocates can really be great leaders to move that transformation, specifically because we have an impact on the other key stakeholders. And so some of those stakeholders, like the industry, for example, have limited impact. Like, we want them to adopt VBHC practices, but they won't necessarily have an impact on payers, for example, or health systems or healthcare providers, whereas patient groups can. So I think we really have a key role to play.
And I would add a couple of other things. I think we should all really be supporting the concept of a pan-Canadian health data system that is consistent, that is efficient, effective, up to the minute, to mention, to your point earlier, Eva, about getting data up to the minute. And I think this is such an important, very important thing for all of us. And and please come to the summit. We are going to have a panel on the whole concept of how to build that kind of a pan-Canadian data system. And one thing that we've done that we hope you'll look at is a declaration of patient rights with relationship to their data. So patients understand perfectly well the importance of sharing their data. Everybody says they don't, but of course we do. And we want it to be used to make our system anti-fragile and teach people, just as these terrible breast cancer data today proved. We need to be measuring things. So we need a robust data system. And to your point, Eva, we need partnerships with other stakeholders. Everybody brings something to the table, but sometimes everybody else is shy to, as I say, call the meeting. So patients are never shy to call the meeting, because nobody expects us to come with the checkbook in our hand. And I think that everybody else fears that that's what's expected of them if they call the meeting. So let's join together and really support these things. And you know, I'm so happy that we're going to have the new president of the Canadian Medical Association speaking at the third day of the summit. That's an amazing partnership that we need to build, and the Public Health Agency on data. We need all of our partners, and we also, of course, must not forget that what is bad for the least of us is bad for the rest of us. So we need to remember health inequities and bring patients to the table to help us build these things, who can make sure that we understand the health inequity lens through which we need to look at our work, for sure.
Yeah, I agree.
So I don't, yeah.
Yeah, we have
So
two other questions in 4 minutes. So I'll address Martine's question. I thank you for your question, and we are actually speaking to Gabriele from Myeloma Canada shortly about this specific topic. Again, related to the first question, I think that where PROM data doesn't exist, where a data set doesn't exist, that's where patient advocacy groups can actually have leadership, use their networks of patient partners, also of scientific and medical advisors, and to really build that together with their communities, but then with other organizations like ICHOM, for example. And there was another question. You want to go for it,
yes,
Louise?
Paul Simpson. Hi, Paul. How are you? I haven't seen you for a while. So why don't you just give us an easy question? Like, how do we change governments because of their provincial election cycles and ministry mandates to think long-term in their healthcare transformation investments? You know, I think if we can educate, first of all, we do need data. We need to prove to them that actually, if they prevent things, they are really doing better for us than when they don't. And I think that if we can build that data system, then they can actually go to their elections saying, guess what? We saved you by doing this. Guess how many lives we saved by doing this? Guess how much money we saved or reimagine and put into different areas and appropriate areas of our healthcare system as a result of that. And they can actually campaign on that. For the moment, since we don't measure anything, they can't prove that what they're doing by preventing is actually saving money, helping save lives, moving money to the right places. Eva, what do you think?
Well, actually, we just had an election like last week, and part of that in Quebec, we actually asked for a 10-year cancer control plan, and so that is a way to, go beyond those electoral cycles, to include in our recommendations. We included things like measuring outcomes that matter, like measuring patient experience, like aligning incentives with value and not with cost. But we need to have that on a long-term strategy and not to always be reactive. Having that approach that we were talking about of predict and prevent and not break and fix, having that long-term vision that enables us to build the future healthcare that we want, not the healthcare that we've had, that, like Louise said, is we don't want to go back to what we had previously. We want to build it, but better. And how do we do that? We have to have a long-term plan with measurable, transparent objectives, data which is real time and public, so that we can hold our governments accountable for delivering the care that they're supposed to be delivering to the population.
Yes, and I would add that we need to assure that our innovation strategies and our health policy strategies are aligned. Because I personally do believe that we put more emphasis on our doctors and our hospitals, certainly in terms of resources and outputs rather than outcomes, as you said before, instead of understanding that if these two are aligned, we can really do a much better job. And, you know, I don't own any stocks in any pharmaceutical companies, to my knowledge. But I'm, you know, there are places where drugs will save us so much more money than sending people to hospitals and having them going to doctors so over and over and over. I just can't, you know, we need those two to be aligned. And so those ministries really need to work together, and researchers and patient groups and all the stakeholders who can make those things mirror each other really need to work together as well. Last night, I was at a presentation where one of the presenters who's in the innovation field said two things for partnerships: transparency and trust. And I'd like you to think about that. That totally resonates for me. I think you could look at some of our government agencies and ask ourselves, do they have transparency and trust? And would we trust them? And if the answer to that with actually anybody is no, we've got a problem.
I agree. So I think we're at time, but we did have one more question that was interesting, hidden in all of the other stuff. Nancy Sorzy asked, what role should pharma play? And it would take a lot longer to give a complete answer, but I think that the short answer is the private sector has often been charged with being the innovators and the ones that take, you know, risks and put the money down and all of that. And so, for example, in our project, the government is interested, but the ones that actually put up the financing to actually test this model was the industry. We have 8 industry partners from the pharmaceutical companies. They're all hands off, but interested in seeing what does it look like when we implement value-based healthcare. So I think that, you know, testing the model, allowing us to do some of that infrastructure work, you know, in terms of like, what kind of data can we use, in terms of applying value-based principles, even in their own submissions to HTA, for example, including some of those quality of life metrics, showing that this medication doesn't just increase overall survival, for example, but also the quality of life, also takes into account patient experience and patient preferences. I think there's a role for pharma to be leaders, but they can't be the only ones. And I think that, like I said before, all the stakeholders have to work together towards that same objective of value from the perspective of patients. Pharma could be leaders, they can be early adopters, but ultimately we need our public healthcare system to also adopt these practices. And so I think that in the early adoption phase, there could be some great role for pharma to play in terms of leadership and in terms of showing that it could be done, you know, taking some of those risks that the government is less, willing to take at the beginning, but then demonstrating that it could be done so that it can be applied in the public healthcare system. And I think that's a great opportunity. And I hope that you're all excited about it as much as Louise and I are.
Thanks, Eva. Yeah, I mean, I entirely agree. I think there's so many things that pharma is doing and can do, and they don't really get much credit for it. They get a lot of tomatoes thrown and not too many kudos. And so, you know, I think they're wonderful partners in terms of making sure that innovation and health policy are linking up and helping us understand where they are delinked and how we can help with that. There's no question they need to come to the table with some innovative solutions to the pricing, the ongoing pricing discussions that go on across the country. And I think they're very sensitive actually to that need. But I understand, you know, that it's not always easy to find just the right partners to help with risk sharing agreements and pay for performance agreements. They really need to support data sharing. Very important. There are many places where I think the industry has a really profoundly important role to play. And again, trust and transparency, you know, just trust and transparency.
I agree, definitely.
So please promise me that you'll sign up for the summit, because we have the federal minister of mental health and addictions speaking, and that's so profoundly important as a partnership in all of the work that we do. Another one of those echo pandemics that needs some anti-fragility, I would say. And as I've mentioned, we do have the incoming CMA, Canadian Medical Association president. I'm so thrilled. We're going to have a lot of good conversations about value-based healthcare, about how data can help us with that. We've even called in the Scots to help us out, our colleagues from Scotland, who have done some amazing work in data collection, and they're going to show us that it's really simple if you just want to do it. So I think, and of course, we have some amazing Indigenous speakers who will help us understand their discrete worldview and cultural norms in relation to healthcare. So very important for us to integrate into everything that we do. So, so please join us. And for those of you who don't know much about the existing healthcare system, which is, it changes, it seems to change daily, please come to our last webinar. Which will at least show you which systems we believe to be in place at the moment at the federal and pan-Canadian and provincial levels. And that'll kind of level set for some of the conversations that we have at the summit. So please join up there if you'd like a little primer or a reminder about that. It's pretty easy to forget all the what I call the Byzantine parts of our of our healthcare system. So thank you so much, everyone, for joining us today. And we'll see you soon.
See you at the summit.
Bye. Thanks again, Eva.
Bye.
As always. Bye.